The widespread prescription of statins for primary prevention in otherwise healthy adults, those with elevated cholesterol but no history of heart attack, stroke, or other cardiovascular events, stands as one of the most lucrative and controversial examples of how pharmaceutical strategy can blur the lines between genuine medical prevention and population-level overreach. While statins like atorvastatin Lipitor, rosuvastatin Crestor, and simvastatin have unquestionably saved lives in high-risk groups, their promotion to millions of low-risk individuals has generated massive profits while raising serious questions about benefit inflation, side effect minimization, and the quiet expansion of disease definitions to create lifelong customers. Statins work by lowering LDL cholesterol, a known contributor to atherosclerosis. For people who have already had a heart attack or have multiple risk factors, what's called secondary prevention, the benefits are clear: reduced risk of another event and lower mortality. But for healthy adults with no cardiovascular disease, primary prevention, especially those with no diabetes, high blood pressure, or smoking history, the benefits are surprisingly marginal. Large meta-analyses have found that for every 100 low-risk individuals taking statins for 5 years, perhaps one major cardiovascular event is prevented, if that. That means 99 people take a daily medication, experience potential side effects, and bear long-term costs for the chance that one may avoid a heart attack or a stroke. From a public health standpoint, that might be justifiable. But for the individual, it's far from a guaranteed life-saving intervention. And yet statins are marketed and prescribed as if they are. Part of this stems from how risk is communicated. Relative risk reduction is commonly used in promotional material and even in guidelines. Statins reduce heart attack risk by 30%. That sounds dramatic until you realize it often refers to relative, not absolute, risk. If your baseline 10-year heart attack risk is 2%, a 30% reduction brings it down to 1.4%. That's a 0.6% absolute benefit, a figure far less likely to inspire someone to take a drug every day for decades. But this less impressive reality rarely makes it into public messaging or patient conversations. The financial incentives to expand statin use are massive. Lipitor alone became the best-selling drug in history, generating over $100 billion in sales for Pfizer before its patent expired. As generics entered the market, companies simply pivoted to newer versions, combination therapies, and broader indications. Meanwhile, guidelines issued by influential bodies like the American College of Cardiology and the American Heart Association continued to lower the threshold for statin eligibility, effectively classifying nearly half of all American adults over 40 as statin candidates. These expanding definitions weren't always driven purely by new evidence. They were often shaped by industry-funded research, advisory panels with financial conflicts of interest, and models that prioritize theoretical population-wide benefits over individualized risk-benefit balance. The risks of statins are not insignificant. Muscle pain and weakness are common complaints, and although often dismissed as subjective or psychosomatic, they can be debilitating for some users. Statins can also impair glucose metabolism, modestly increasing the risk of type 2 diabetes, especially in older adults. Some users report cognitive side effects, such as memory fog or reduced mental clarity, though the evidence is mixed. Regardless, these side effects are rarely emphasized in promotional messaging and are often downplayed in clinical practice. In many ways, the statin story is about more than just one class of drugs. It illustrates how the language of prevention has become a commercial goldmine. By medicalizing risk factors like cholesterol levels, not disease states, pharmaceutical companies have successfully turned healthy people into patients. This subtle shift reframes everyday variation in lab numbers as something pathological, requiring lifelong treatment. It's the perfect business model. A chronic condition that affects half the adult population, requires no symptomatic presentation, and demands daily medication indefinitely. What gets lost in this narrative is nuance. Lifestyle interventions, diet, exercise, sleep, stress reduction, are often more powerful than statins in truly low-risk populations, yet they are harder to monetize, require behavior change, and don't involve a monthly prescription. Instead, patients are told, "Your cholesterol is high. Take this pill." It's quick, scalable, and profitable, but not necessarily in the best interest of the patient. Statins may still be the right choice for some individuals in the gray zone between low and moderate risk, particularly those with strong family histories or emerging risk markers. But the fact that they are so aggressively promoted, despite modest benefit in many such cases, suggests that financial motivations have too often eclipsed clinical judgment. When drug companies fund the studies, influence the guidelines, shape the messaging, and profit from the outcome, the objectivity of that ecosystem becomes dangerously compromised. Ultimately, the mass prescription of statins for primary prevention reflects a medical culture that increasingly treats risk as disease and aging as pathology. It's not inherently fraudulent, but it is deeply shaped by commercial forces. And those forces have led millions to take daily medication for a theoretical benefit, based on an overstated narrative of danger and an understated set of trade-offs. The profits are undeniable. The benefits? Not nearly as universal as advertised.